Welcome back to the deep dive. Today we're effectively becoming detectives.
Ooh, I like that.
We have a stack of clinical guidelines, some surgical protocols, and pathology notes right here on the desk, and we're going to use them to solve a very specific kind of medical mystery.
Right.
It's a problem that is incredibly common, often, terrifying for the patient, and it requires a very cool head to navigate. We are talking about the solitary thyroid nodule.
It sounds deceptively simple, doesn't it? A nodule, just a little bump. But you are absolutely right to frame this as detective work.
Uh-huh.
In the world of endocrinology and head and neck surgery, the solitary thyroid nodule is really the ultimate puzzle of risk stratification.
And the stakes are high. I mean, from what I've been reading in these materials, while the vast, vast majority of these lumps are harmless, this is the most common way thyroid cancer actually presents itself.
Exactly, and that creates a very specific kind of tension in the clinic. The patient feels a lump, and their mind immediately goes to cancer.
Of course.
But the doctor feels the lump and thinks, statistically, this is probably benign, but I have to prove it. We operate on a mantra, really. Malignant until proven otherwise.
So the entire mission of today's deep dive is to walk through that whole process. How do we filter all that noise to find the actual signal?
That's it. We're going to build a full clinical framework here. We'll start with the definition, which is, actually a little trickier than it sounds.
Okay.
Then we'll move into the interrogation phase with the patient's history, break down all the high-tech imaging tools, and finally we'll end up at the surgical decision tree.
The goal really is to give you, the listener, the tools to understand how a clinician looks at a neck mass without getting overwhelmed by the anxiety of it all.
Think of it as a roadmap. We start with this wide funnel of people with lumps, and we systematically, step by step, narrow it down to people who actually need surgery.
Okay, so let's start at ground zero, the definition. When we say solitary thyroid nodule, or STN for short, are we just talking about, any lumpy neck?
Strictly speaking, no. The textbook definition is very, very precise. An STN is a single, clinically palpable, discrete swelling in a thyroid gland that otherwise feels completely normal.
And clinically palpable just means you can feel it with your fingers during an exam.
Correct. You feel one distinct island in a sea of, well, normal tissue. But here's the first twist in our detective story. It's a big one. There's a massive disconnect between what is clinically solitary and what is radiologically solitary.
You mean what your fingers tell you might be a lie?
It's not necessarily a lie, but it's an incomplete truth. You might feel one dominant lump. You write down solitary nodule on the chart.
Right.
But then you send that patient for an ultrasound, which sees much deeper and with much more clarity than your fingers can feel. And suddenly you see 3 or 4, maybe even 5 other tiny nodules scattered around the gland.
So the patient actually has what's called a multinodular goiter, but one bully is just like shouting louder than all the others.
Precisely. In fact, some studies show that a significant percentage, we're talking up to 50% of patients with a solitary nodule, actually have multiple nodules on their imaging.
Wow. So does that distinction change the game? If I go in thinking I have one lump and I find out I have 5, should I be more worried or less worried?
You might relax a tiny bit, statistically speaking, because multinodular goiters are often just degenerative changes over time. However, clinically, our approach doesn't change at all.
Okay.
We have a rule. If there is a dominant nodule, one that is distinct or harder or growing out of proportion to the others, you treat it with the exact same suspicion as a true solitary nodule.
So you can't let the background noise of the other little bumps distract you from the main suspect.
Exactly. Don't let the crowd hide the culprit.
Speaking of culprit, let's look at the lineup. If we were to biopsy this lump right now, what are the possibilities? Who are the usual suspects?
The lineup is a mix of the innocent, the misunderstood, and the dangerous. The most common suspect by a long shot is the colloid nodule.
Which is what, exactly?
Essentially, it's a storage issue. The thyroid's made of these little follicles that store colloid, which is a jelly-like substance full of hormones.
Okay.
Sometimes a section of the thyroid just gets inefficient and overfills. It becomes a distended bag of colloid. It's a completely benign process, basically an overgrowth of normal tissue storage.
So that's our innocent bystander.
Completely. Then you have cysts. These are simple fluid-filled sacs, also benign. Then you get to adenomas. Now, an adenoma is a neoplasm. It's a new growth, a tumor. But it is benign. It's a ball of cells growing, but they aren't invading anywhere.
And then standing at the end of the lineup, the one we are actually hunting for.
Thyroid carcinoma, cancer. And even though carcinoma is the minority, maybe 5 to 10% of these presentations, the entire medical workup is designed solely to catch that one guy.
It's a process of elimination then.
It is. We have to peel away all the benign possibilities until we are either left with a cancer diagnosis or we're confident enough to say, you're safe.
Okay, let's walk into the exam room. The patient is sitting there. You've spotted the lump. Before we even touch the patient, we need to get the story. What are the key questions that help us differentiate the innocent storage room from the dangerous tumor?
The history taking is our interrogation phase. We're looking for red flags. The first clue is always time. How long has it been there? Is it growing?
My intuition would say fast growth is bad. If something doubles in size in a month, that sounds like cancer.
And generally, yes, you'd be right. A rapid, sustained increase in size is concerning for malignancy, particularly aggressive types like anaplastic carcinoma or lymphoma. But, and then this is a very important nuance for you to understand, sudden explosive onset is usually not cancer.
Right, define explosive.
I mean, a patient says, "Doctor, I went to bed fine and I woke up with a golf ball in my neck."
That sounds absolutely terrifying. If I woke up with a lump like that, I would assume the worst.
It is terrifying, absolutely. But cancer is usually a slow builder. It takes its time to divide and conquer. If a lump appears literally overnight, it's usually physics, not biology. It almost always means there was a hemorrhage, a bleed inside a pre-existing cyst or nodule. The balloon just filled up with blood instantly.
And does that hurt?
Yes, usually it's quite painful because the capsule of the thyroid is being stretched so rapidly.
So, strangely enough, sudden pain is a sign that points away from cancer.
Correct. In the context of thyroid nodules, pain is a very confusing signal. Cancer is usually a silent, painless intruder. It just creeps in. So if a patient comes in with a painful sudden lump, I'm actually thinking more about hemorrhage or maybe inflammation, like a viral thyroiditis rather than carcinoma.
That is a crucial distinction. It hurts does not equal it's killing me.
Yep.
So if pain isn't the smoking gun, what is? What is the one symptom that makes a surgeon's blood run cold?
Hoarseness.
A change in your voice.
Specifically, a new, persistent hoarseness or a breathy quality to the voice. This comes down to pure anatomy. The thyroid gland sits directly on top of the trachea, your windpipe,
Right.
and running right behind the thyroid, tucked into this little groove between the trachea and the esophagus, is the recurrent laryngeal nerve.
The RLN.
Right. And this nerve is the power cord for your vocal cords. It makes them move. Now, a benign nodule, even a really big one, it just pushes things aside. It's polite. It might bulge. It might shift the windpipe over, but it respects boundaries.
And a malignant nodule.
A malignant nodule does not respect boundaries. It invades. So if a patient has a hard thyroid lump and their voice has become hoarse, it implies that the tumor has grown out of the thyroid capsule and has physically invaded that nerve, paralyzing the vocal cord on that side.
Wow. That's not just a symptom. That is direct evidence of invasion. That changes the staging immediately.
It shifts the stage from local nodule to locally advanced cancer instantly. That is the single biggest red flag in the history.
What else are you looking for?
Other flags we look for include radiation exposure, especially childhood neck radiation, which was common decades ago for things like acne or enlarged tonsils, and a family history. Genetics can play a huge role here.
So we've interrogated the patient. Now we do the handshake with the neck. We're palpating the thyroid. Describe the tactile difference. If you close your eyes and feel a neck, what differentiates a good lump from a bad lump?
We look for two main things: consistency and mobility. A benign colloid nodule or a cyst feels approachable. It's usually soft or maybe firm elastic, kind of like the tip of your nose or a grape.
And it moves.
Crucially, yes, when the patient swallows, the whole thyroid gland moves up and down. A benign nodule moves with the gland. It's not stuck to anything else.
Okay, now describe the villain.
A malignant nodule feels hard. We describe it as stony hard or wood-like. It feels distinct and rigid. And even more concerning is fixity.
Fixity meaning it's stuck solid.
If you try to wiggle that nodule and it feels glued to the muscles of the neck or the windpipe itself, that suggests it has grown roots. It's infiltrating the surrounding structures. That is a very, very bad sign.
And you mentioned the nerve earlier. Can we check the nerve physically, or is it just by listening to the voice?
You can't feel the nerve, no, but you can check for its accomplices. We feel for cervical lymphadenopathy.
The lymph nodes in the neck.
Exactly, the drainage system. Thyroid cancer, especially the most common kind, papillary carcinoma, loves to travel to the local lymph nodes. So if I feel a hard nodule in the thyroid, and then I feel a firm, enlarged lymph node on the side of the neck, well, the probability of cancer just skyrocketed.
And that's a sign of spread.
We call that the lateral compartment. If the disease is there, it's already spread outside the gland.
Okay, we've gathered our physical evidence. We have a history. We have a feel for the lump. But we are modern detectives. We don't just guess, we verify. Where do we start with the toolkit? Is it blood work?
Always start with the basics. We order thyroid function tests, T3, T4, and TSH.
But wait, looking at our notes here, it says that most people with thyroid cancer have normal hormone levels. So why bother with the blood test if it probably won't find cancer?
You're absolutely right. Most patients are what we call euthyroid. Their function is normal. The cancer doesn't usually mess with the hormone production factory. It just sits there occupying space. But we do the blood work to rule out the other possibility. We're looking for the hot nodule.
Okay, you have to explain this concept of hot versus cold. This refers to how the nodule acts on a scan, right?
It refers to its function. So the thyroid's job is to take up iodine from the blood and turn it into hormone. If the blood work shows a suppressed TSH, meaning the brain is screaming, "Stop making hormone," but the hormone levels are high, we suspect the nodule is acting like a rogue factory. It's pumping out excess hormone all on its own.
We call that a toxic adenoma.
Right. And if we were to do a radionuclide scan, where we give the patient a tiny bit of radioactive iodine, this nodule would grab all of it. It would light up like a Christmas tree on the image. We call that hot.
And here's the paradox I really want to understand. A hot nodule, which is overactive and rogue, is actually safe.
Paradoxically, yes. A hot nodule is almost never cancer.
Why is that? That seems so counterintuitive.
It comes down to cellular biology. To make thyroid hormone, a cell needs to be highly organized. It needs all the machinery, the iodine pumps, the enzymes, to be working perfectly. Cancer cells, by their nature, are disorganized, they're mutated, they're inefficient. They generally lose the ability to pump iodine and make hormone.
So a cancer cell is a broken factory.
It's a broken factory, exactly. So if you find a nodule that is working overtime, a hot nodule, you can basically guarantee it's benign. You treat the hormone issue, of course, but you stop worrying about cancer.
That is a huge off-ramp in our decision tree. If TSH is low, scan it. If it's hot, relax.
Ideally, yes. But here's the catch. For the vast majority of patients, their TSH is normal. The nodule is cold. It's non-functional.
And a cold nodule could be cancer.
It could be. But, and here's the frustration of it, most benign nodules are also cold. A colloid cyst is cold. A regular adenoma is often cold. So finding out a nodule is cold doesn't actually give us a diagnosis. It just tells us we can't rule cancer out yet.
So the blood work and the radionuclide scan are good at ruling out cancer in some rare cases, but they're pretty bad at finding it in most common cases.
That's a perfect way to put it. Which brings us to the real eyes of the operation, the ultrasound.
Right. Ultrasound has become the extension of the endocrinologist's hand, hasn't it? What are we looking for on the screen? We aren't just measuring size, are we?
No, size is secondary. It's important, but it's secondary. We are looking at the architecture of the nodule. We are risk stratifying based on specific visual features.
Give us the good versus the bad visual profile.
A good-looking nodule on ultrasound is often purely cystic, just a black circle of fluid, or it has what we call a spongiform appearance. It looks like a honeycomb. These are almost always benign.
And the bad profile, the one that makes you worried.
We look for solid hypoechoic nodules. Hypoechoic just means it looks darker than the surrounding muscle, which suggests it's dense with cells. We look at the margins. A benign nodule often has a nice halo, a smooth rim pushing tissue aside. A malignant nodule has irregular, jagged, or infiltrative margins. It looks more like a splatter than a neat ball.
Our sources mention a very specific marker called microcalcifications. Now, that sounds like something you'd need a microscope for, but you can see them on an ultrasound.
You can. They're these tiny, bright, sparkling specks inside the nodule. On the screen, it literally looks like someone sprinkled salt or diamond dust inside the tumor.
That sounds almost pretty, but I'm guessing it's not.
It is definitely not pretty clinically.
Yeah.
These represent something called psammoma bodies, which are microscopic calcified structures that form when cancer cells die and then calcify. If you see microcalcifications, it is a very, very strong indicator of papillary thyroid carcinoma. It's practically a fingerprint.
Okay, so let's set the scene. We have a patient. They have a solid, cold nodule. The margins look a bit fuzzy on ultrasound. Maybe there is a speck of calcification. We are worried. We can't just guess anymore. We need physical proof. This brings us to the golden standard.
FNAC, fine needle aspiration cytology.
This seems to be the pivot point of the entire management plan.
It absolutely is. You can do all the fancy imaging you want, but eventually, to treat a patient, you need to know what the cells look like. FNAC is the investigation of choice. It's simple, it's safe, and it's highly accurate for what it does.
Walk us through the procedure briefly. How does it work?
It's done right in the clinic or the radiology suite. We use the ultrasound to guide a very thin needle, thinner than what we use to draw blood right into the center of the nodule. We aspirate or suck out a few thousand cells. We smear them on a glass slide, stain them, and a pathologist looks at them under a microscope.
And the pathologist gives us a verdict. I understand we use something called the Bethesda system to report this.
Yes. The Bethesda system for reporting thyroid cytopathology, it's a standardized way of talking so that surgeons and pathologists and endocrinologists are all on the same page. It scores the biopsy from category 1 to category 6.
Let's run through these quickly because they really dictate what happens next to the patient.
Okay. Category 1 is non-diagnostic.
Yeah.
It means we missed or there was too much blood. We just have to do it again.
Right.
Category 2 is benign. This is the best news you can get. It's a colloid nodule. The risk of cancer here is tiny, less than 3%. We can just observe these patients.
Okay, let's skip to the end. Category 6.
Category 6 is malignant. The pathologist sees frank cancer cells, no question. That patient goes to surgery for a thyroidectomy.
Okay, that all makes sense. Benign means watch, malignant means cut. But there is a massive gray zone in the middle, specifically Bethesda category 3 and 4, the so-called follicular dilemma.
This is without a doubt the most fascinating and frustrating part of thyroid pathology.
Explain this to me because it seems like a major limitation of the technology. Why can't the needle just tell us if it's cancer?
It has to do with how follicular carcinoma works. Papillary carcinoma, the common one, has cells that look weird. They have strange nuclei. A good pathologist can spot them a mile away. But follicular cells,
Yeah.
imagine I show you a bucket of oranges, and I ask you, did I buy these at the grocery store, or did I steal them from a restricted orchard?
I wouldn't be able to tell. They're just oranges.
Exactly. The oranges themselves look the same. In this analogy, the follicular adenoma, which is benign, and follicular carcinoma, which is malignant, are made of the exact same cells. They look identical under the microscope.
So how do you ever tell them apart?
By behavior, by context. The definition of follicular carcinoma is that the tumor is invading its capsule, the wrapper around it, or it's invading the blood vessels. It's all about the architecture of the boundary.
Oh, I think I see where this is going. The needle sucks out the cells, the oranges, but it doesn't show you the boundary.
Bingo. The needle gives you the cells, but it doesn't show you the fence line. It doesn't show if the tumor is breaking and entering. So the pathologist cannot call it cancer. They have to report it as a follicular neoplasm or Bethesda category 4. They are essentially saying, I see a tumor made of follicular cells, but I cannot tell you if it is benign or malignant.
That is a massive cliffhanger for a patient. You found a tumor, but we don't know if it's cancer. So what do? You can't just leave it in because it might be cancer, but you don't know for sure.
This forces our hand. We have to perform surgery not necessarily to cure, but to diagnose. We call it a diagnostic lobectomy or a hemithyroidectomy.
We have to take half the thyroid out just to get the answer.
Yes. We remove the entire lobe containing the lump. The pathologist takes that lobe, slices it up like a loaf of bread, looks at the capsule interface under the microscope, and only then can they give us the final answer. If the capsule's intact, great, it was an adenoma, you're cured. If the capsule's breached, it's carcinoma.
That brings us perfectly into the surgical decision phase. We are at the end of the detective story. We finally have to act. Let's clarify the types of surgery.
Broadly, we have two main options. A total thyroidectomy, taking the whole gland out, or hemithyroidectomy, taking just half of it out.
If the biopsy comes back as Bethesda 6 malignant, we usually go for a total.
Usually, yes. If we have confirmed cancer, the standard of care is often to clear the entire field, especially to address any microscopic spread to the other side and to make any follow-up treatment easier.
And for our follicular, maybe the Bethesda 4, we do the hemithyroidectomy.
Correct. It perfectly balances the risk. We get the diagnosis, and if it turns out to be benign, the patient still has half a thyroid left to produce hormones, so they might not need medication for the rest of their life.
Let's talk about the surgery itself for a moment. The neck seems like incredibly crowded real estate. You have the windpipe, the esophagus, the big blood vessels, the spine. What are the dangers? What are the main principles a surgeon follows in there?
It is a surgery of millimeters. We have 3 key jobs inside the neck, aside from actually removing the tumor, of course. We have to identify and meticulously protect the vital structures.
Priority number 1 has to be
the recurrent laryngeal nerve. We just keep coming back to this nerve. It is the absolute star of the show.
because if you cut it,
If you cut it on one side, the patient wakes up with a permanently hoarse, breathy, weak voice. It's debilitating. If you were to damage both nerves, which is a catastrophic surgical error, both vocal cords can flop shut in the midline and block the airway. The patient can't breathe. They might need a permanent tracheostomy.
So in the operating room, you aren't just trying to avoid it, you are actively hunting for it.
Absolutely. The gold standard is to physically visualize the nerve. We dissect it out gently from its surrounding tissue to make sure we know exactly where it is before we clamp or cut anything near it.
And priority number 2.
The parathyroid glands. These are 4 tiny glands, usually the size of a grain of rice or maybe a lentil, that sit on the back surface of the thyroid.
And what do they do?
They control the calcium levels in your blood. That's their only job.
They sound really easy to miss.
They are very easy to miss. They often look just like little globules of fat. And, crucially, they share the blood supply with the thyroid. When you are cutting off blood vessels to remove the thyroid, it is very easy to accidentally cut off the blood flow to the parathyroids.
And if you damage them or even just stun them?
The patient develops hypocalcemia low calcium. This is the most common complication of thyroid surgery. It usually shows up 24 to 48 hours after the operation when the patient starts to complain.
What are the signs? What do they complain of?
Tingling. We call it circumoral paresthesia, a specific tingling around the lips, or tingling in the fingertips.
That's a very specific moment for a clinician on the ward.
It is. If a post-op thyroid patient says, "My hands feel fizzy," you check their calcium level immediately. If it gets worse, their hands can cramp up into a painful spasm. We call it Trousseau sign. Or if you tap their cheek, the facial muscles twitch Schwarzkopf sign. These are classic signs of neuromuscular irritability caused by low calcium.
So you have to preserve the voice, preserve the calcium. What's the third job?
Clearing the pyramidal lobe.
Pyramid.
It's an anatomical quirk. The thyroid actually develops at the base of the tongue and migrates down the neck during fetal development. Sometimes it leaves a little track behind. The pyramidal lobe is a little finger of thyroid tissue that stretches up from the center of the gland towards the hyoid bone in the neck.
And if you leave it behind?
It can grow back.
Yeah.
Or if you're treating cancer, it can be a site for recurrence. So a good thyroidectomy isn't just taking the main 2 lobes, it's chasing that pyramidal lobe up the neck to ensure you've been thorough.
It really highlights that this is a technical art form. Before we wrap up the clinical pathway, I want to circle back to one big differential diagnosis point. We talked about solitary nodule versus a multinodular goiter, or MNG. Is MNG safer?
That's a common misconception. Statistically, per patient, the risk of cancer is slightly lower in MNG because MNG is often just a sign of an aging, maybe iodine-deficient thyroid. It's lumpy and grumpy. But the trap is complacency. The trap is seeing a lumpy neck and just saying, "Oh, it's just a goiter. See you next year."
The dominant nodule rule again.
Yes. If you have a bag of marbles and one of those marbles is made of steel, you have to find it. If an MNG patient has one nodule that is significantly different, it's dominant, it's hard, it's growing, you have to evaluate it exactly as if it were a solitary nodule. Cancer can absolutely hide in a benign-looking goiter.
Okay, let's distill this all down. We've covered a massive amount of ground, from the definition to the operating table. I want to do a rapid-fire round to lock this in for the listener. I'll throw a scenario or a concept at you, and you give me the pearl, the truth, and the pitfall, the mistake people make.
I love it. Let's do it.
Scenario 1. A patient comes in with a painful lump that appeared overnight.
Pearl. It's likely hemorrhage into a cyst. It's almost certainly benign. Pitfall. Rushing to diagnose cancer and frightening the patient unnecessarily.
Scenario 2. The hot nodule on a scan.
Pearl. If it's functioning, it's benign. Treat the hyperthyroidism. Pitfall. Biopsying it. You do not need to stick a needle in a hot nodule. It's a waste of time and money.
Scenario 3. Hoarseness of voice.
Pearl. This indicates nerve invasion. It is a high-grade red flag.
Yeah.
Pitfall. Assuming it's just pressure from a large goiter. No. It changes the staging to locally advanced cancer.
Last one. Scenario 4. Bethesda Category 4. Follicular neoplasm.
Pearl. The needle can't see the capsule, so we don't know the answer. Pitfall. Thinking that a benign-looking biopsy means you are safe. You are not. You need a diagnostic lobectomy to definitively rule out carcinoma.
That last one really sticks with me. It just highlights that medicine isn't always black and white. There's this huge gray zone where we still rely on surgical exploration.
We do, and that's why the solitary thyroid nodule is such a classic topic for medical education. It forces you to use everything: your hands for the exam, your history-taking skills, your understanding of physiology, and your surgical judgment. It's not just a lump, it's an entire decision tree.
And there is a philosophical point here too, isn't there? We call it diagnostic surgery.
It's a heavy phrase, if you stop and think about it. It implies that all of our non-invasive technology failed. We have to remove an organ or half of one just to answer the question, was this bad?
It highlights the limitations we still face.
It does. But it also highlights the safety net we build for patients. We would much rather remove half a thyroid unnecessarily than miss a cancer that could spread. It is a calculated risk based on the Bethesda system, not just on fear.
And for you, the listener, the takeaway is awareness without panic.
Correct. Most nodules are benign, but every nodule deserves a name. Once you name it, colloid, cyst, adenoma, or carcinoma, then you can manage it. But you can't manage what you haven't defined.
So be systematic. Don't ignore the changes in your body. And if you feel a lump, get the detective work started.
You couldn't said it better myself.
Thank you so much for guiding us through this whole investigation today. It really clarifies why doctors ask the questions they ask and do the things they do.
My pleasure. It's a truly fascinating topic.
And to you, the listener, thanks for joining us on this deep dive. Whether you're a student, a practitioner, or just someone interested in how the body works, we hope this gave you a new perspective on what goes into that whole decision-making process. Keep asking questions, keep digging deeper, and we'll see you on the next one.